about upcoming echoes, my email is E as in Emily, Field, F-I-E-L-D, at usetinc.org. That's one field. And that is all I have.
We'll turn it over to Dr. Mara to present updates on COVID-19.
Okay, thank you, Brian. I'm sorry. Okay, you all know this is a very dynamic process and information changes on a daily basis. So I selected a few of the manuscripts or information that I thought was relevant, but a lot of it's coming out today. And there's a lot of information on serology, so if anybody has questions on serology, I'll address them. But I don't have a slide included on serology yet. Okay, so there's been a lot of noise in the news regarding the origin of COVID-19, and even alluding to that this could have been a laboratory-made virus and spread out by accident or intentional reasons, etc. So I did do a search to see what was published in scientific papers, and I found this very interesting article published in Nature, which is a reputable magazine, as you all know. And the authors, who are molecular virologists, and their detailed description is beyond my scope of practice, but I did find it very interesting. And they thought that it is very improbable that SARS-CoV-2 emerged through laboratory manipulation. So they did the genetic sequencing, and what they allude is that normally when you want to manipulate viruses, you have to start with a backbone of known viruses. And by the sequence that they did on the coronavirus that's causing the pandemic, they could not find any evidence that this was fabricated in a laboratory. So I quote them: if generic manipulation had been performed, one of the several reverse genetic systems available for beta coronaviruses would probably have been seen. However, the genetic data irrefutably shows that SARS-CoV-2 is not derived from any previously used virus backbone. And they go on and actually comment on what the theories are of how this COVID-19 came about. And they propose two theories. One could be natural selection in an animal host before the virus jumped into humans. And the other one is that the virus jumped into humans and then there was natural selection in the humans and made the virus what it is today. So, it's got a lot of details to this manuscript, very interesting. And I put the reference down there if you're interested. So right now we cannot say with evidence that this virus comes from a laboratory. For all of you who engage in CPR, there has been an update of the American Heart Association guidance for CPR in the COVID era. During CPR, there are a lot of aerosols that are generated during intubation, ventilation, chest compression, etc. This is a very detailed report, and if you are involved in CPR in any way or form, I would encourage you to review this. I've just mentioned here on the right-hand side some of the highlights. So they mentioned all rescuers should don personal protective equipment before entering a scene to protect themselves against airborne and droplet particles. So it's very important that nobody becomes a superhero and jumps to resuscitate someone without proper PPE, because then you will become a victim. And if you have to be quarantined because you're exposed, you're going to be out of commission for 14 days, and you will not be able to help a lot of the people that you need to help on a daily basis. So be careful and cognizant of that part. Then you should limit the personnel on the scene to those who are essential for patient care. Of all of those who've done CPR, you will know that usually, especially CPR inside a hospital setting, generates too many people inside the room where the CPR is being conducted. And so now you really need to limit that amount to the handful that really need to be there. And they also recommend rescuers should consider replacing manual chest compressions with mechanical CPR for patients who meet the manufacturer's criteria. And also that COVID-19 status should be communicated to any new providers before arrival on the scene or when transferring the patient to a second setting. I personally have some I don't agree with this too much. I think we should treat everybody that needs CPR as if they were COVID positive. If we rely on information, you can have the problem that people think their patient's negative and they don't take all the precautions. But I mean, that's what they say. And they go in a lot of details during the intubation procedure, bagging, using HEPA filters in your equipment. So I think it's a very good guideline update. And as I said, if you're involved in this, I would consider you reviewing it. I would recommend that you review it. So when I read this a week ago, it made some sense, but yeah, now you'll see that it doesn't make too much sense anymore. This was a study done in monkeys, macaques, who they did an animal model for SARS-CoV-2 infection. So they infected two groups of rhesus macaques with SARS-CoV-2 and then randomized the group. One of the group was treated with intravenous remdesivir, which is a polymerase inhibitor for COVID-19. And the other group just received the solution, the vehicle solution only, without the antiviral. And when they proved after 7 days that the monkeys who did not get the antiviral had more pulmonary infiltrates and more symptoms of the disease compared to the monkeys who got the antiviral. And when they did the autopsies at 7 days, the monkeys who got the antiviral had a clear reduction in damage to the lung tissue compared to the ones who did not. So they concluded that therapeutic remdesivir treated initially early during the infection has a clear benefit in monkeys. So, you know, if you want to extrapolate, if you're going to use it in humans, you should probably use it earlier than later. I thought that was very interesting and also justified the sacrifice of some monkeys if the information was good. Although not everybody will agree with this last statement. But not today, comes from the news that the first clinical randomized trial of remdesivir in China did not show any benefit. I have not read that report. Apparently this was an internal report to the WHO and it was leaked in the news. And so I have not read the details of the report. The summary in the news is that at 150 who were randomized to receive remdesivir, and 79 other had standard of care or placebo. The mortality was the same, but I don't have the details on when these patients got treatment, etc. It did cause a big plummet in the stock market for Gilead, but I don't know if Gilead's going to pull it out or not, or they're just going to wait until they have the other clinical trials. But when I read when the paper comes out and I get a good look at it, I'll give you my input on it. So those who were present in our last meeting, I gave a little presentation on ACE inhibitors and ARBs in the context of COVID, of the COVID pandemic. And there was controversy in regards, are these medications helpful or are they dangerous in patients who get infected with COVID-19? Because as you may remember, the COVID virus enters the cells through an ACE2 receptor. And that ACE2 receptor may be increased in patients who are getting ARBs or ACE inhibitors. Now, on the other hand, that ACE2 receptor has an important effects on the homeostasis of angiotensin II, which in excess can cause cell damage. So some authors would say it may be good to be on an ARB or ACE inhibitor. Some others thought it could be a problem because you have more receptors and therefore you can get more virus attached to the cells. Anyway, there was a study. There's two studies now, but this is the one I analyzed this week. This comes from China. And to make it simple, in a cohort of patients who were in the hospital for COVID-19, they chose 1,128 patients who had hypertension, and of those, they dissected those who were on ARB or ACE and those who were not, and they did a case control study. And if you look at the graph on the right-hand side, you can see that the patients who were receiving an ACE inhibitor or an ARB, that's an angiotensin receptor blocker, the death rate was much lower, statistically significant, compared to those who were not receiving an ACE inhibitor or an ARB. So the bottom line of this case control study is that in hospital use, ACE and ARBs are associated with a reduced 28-day all-cause mortality, and this kind of reinforces the recommendations of the American Heart Association that you should not stop these medications on patients who are taking them because they need them to treat their hypertension or congestive heart failure or kidney disease, or whatever the good reason is. So this reinforces that. And there was another study that I don't have here today that shows similar data, but I have not read the details of that data to present it to you. So, okay, this is just a follow-up with all the steps of why, you know, COVID-19 and hypertension and the use of ACE inhibitors are related in some way or form. And the final recommendation is that it supports the recommendations of the American Heart Association, not stopping them. I'll leave this slide for your review in case you want to go line by line. So another hot topic is, does hydroxychloroquine work or not? And we still do not have a randomized clinical trial data available for us to know this with certain precision. But this is the best study so far that comes from the VA hospital. And what they did a national retrospective cohort study of male patients with laboratory confirmed COVID-19 infections in inpatients. So it's important to know that this does not include females. And the reason is because they had so few females in the cohort that they just excluded them because they couldn't make it an analysis because of the low numbers. So this only applies to males, and it only applies to patients who are admitted to the hospital. So there's certain disease severity involved in this cohort. And they measured outcomes was the patient discharged or did the patient die? And also, did the patients need mechanical ventilation or not? And also, of those who did require mechanical ventilation, did they die or were they discharged from the hospital? So a very clear-cut outcomes measurements. They developed 3 cohorts based on the use of hydroxychloroquine and azithromycin. So the first cohort were patients treated with hydroxychloroquine. The second cohort had hydroxychloroquine and azithromycin. And the third cohort did not have hydroxychloroquine in part of their treatment during the hospitalization. So I made this table to try to tease this in the simplest form possible. So in the first column, you have the outcomes. Did the patients die? Did they require mechanical ventilation or not? Or where was the risk of death after mechanical ventilation? When we looked at the first row regarding death, the patients who received hydroxychloroquine, 27.8% died, compared to 22% on the ones who also had azithromycin on board, and 11% of those who had no hydroxychloroquine on board. And this was statistically significant only for the hydroxychloroquine group compared to no hydroxychloroquine, meaning that if you got the medication, your chances of dying were higher. There was no statistically significant difference between the combination of hydroxychloroquine and azithromycin compared to no hydroxychloroquine. Regarding mechanical ventilation, they could not find a statistically significant difference among the 3 groups, although the percentages are a little bit different. There was no statistical significance difference, meaning no matter what you got treated with, your chances of ending up in a vent were the same. And also, when you were on a ventilator, your risk of dying did not matter if you did get or did not get hydroxychloroquine alone or hydroxychloroquine plus azithromycin or nothing. So the author's conclusions, which I agree based on the data they presented, is that hydroxychloroquine used with or without co-administration of azithromycin did not improve mortality or reduce the need for mechanical ventilation in hospitalized and I would add male patients. Actually, hydroxychloroquine alone was associated with an increased mortality. And the baseline characteristics of these patients regarding age, morbidity, and comorbidities was very similar on the three groups. But the patients who received hydroxychloroquine and with or without azithromycin tended to be a little bit sicker. And that's what you see in non-randomized controlled trials. You usually tend to give medications to patients you think may benefit from that most. So that is a bias. But these authors did some very nice statistical work to try to account for that bias. And after they did those analyses, they still could not find any benefit of giving hydroxychloroquine, and they even found that mortality was still high if you got the medication. The other important thing is that the fact that the need for ventilation, mechanical ventilation, did not differ among the groups tells you that if receiving hydroxychloroquine has higher mortality, it's not attributable to something occurring in the lung, not the virus itself. It's probably something occurring in some other organs. And the assumption is that hydroxychloroquine can cause QT prolongation, and maybe, this was not confirmed in the study, but maybe that could have been the reason why these patients had higher mortality. And then finally, they make very clear that this does not necessarily apply to women or younger hospitalized populations or patients who are outside of the hospital or pediatric population. So I thought it was a very nice study, a nice, very nice case control study. Still, we need the results of the randomized clinical trials. But after we saw this study in our hospital, we decided to stop using hydroxychloroquine until we get the RCT reports and have better data. And that is all I have for you today, and I'd be happy to take any questions. Thank you.
We don't have any questions as of yet in the chat. If we want to move ahead and with the epi update, Christy, let me share my screen.
Thank you, Brian. I appreciate it. Good afternoon, everybody. I appreciate you coming to this presentation. I wanted to just go over with you, well, first of all, let me introduce myself. My apologies. My name is Christy Duke, and I am the Senior Epidemiologist with the Tribal Epidemiology Center at USET. I want to offer a disclaimer before I get started. So I've noticed over the course of this pandemic that there is quite a lot of public misinformation and old information that is out there. The information coming from the research and the data that Dr. Mira touched on, things are changing extremely rapidly. I know I had a conversation yesterday with my boss, and he said to me, "Didn't you just say something different 3 weeks ago?" And my answer was yes, I did. But we are learning new things fairly rapidly, and we're trying to update the information as soon as we give it and provide updated guidance to you guys. But be aware that things are changing very rapidly, and advice is changing as this pandemic goes on. So I just want to make everybody aware of that and just state that publicly. We will, anytime we issue updates from previously issued guidance, we will notate that on the guidance that it has been updated and changed. So today I'm just going to talk very briefly about Nashville area COVID-19 epidemiology and surveillance, and just give you a high-level overview of what we're seeing from week to week. And then, because there is so much information coming out about reopening services and about what that's going to look like, and because the Nashville area encompasses such a wide region, I going to want to go back to the basics and talk about flattening the curve and what that means and what that might look like in the face of reopening. This past week, I've heard a whole lot about mass testing, meaning let's just test everybody. But I want to think through that a little bit with you today and think through what that might mean for public health and the implications on public health. Then I'm very briefly going to just talk about a couple of innovative strategies, public health strategies that I've heard about. And I would like to put this request in now. If your tribal nation or site has some innovative approaches to public health regarding COVID-19, or even just something you're thinking about and would like to bounce it off the other participants on this call, please bring it up. I think that this is an excellent forum for us to be able to brainstorm and share ideas with each other. And after that, I'll take questions on this presentation. This presentation is really going to focus on the very basics of mass testing and the current tests that are out there and what that might mean. As a follow-up to that, next week's presentation, Dr. Harry Brown, who's our medical epidemiologist, who some of you may remember was the area office's chief medical officer a few years ago, he is going to go into more detail about each test and how to interpret the results and what the impacts of those specific tests are on public health. And that's going to happen next week. So this is really going to be a progression of a very complex topic. So I'm going to start with the basics this week, and then Dr. Brown will expand on that next week. So the Nashville Area COVID-19 Epidemiology. This week we had 23 sites reporting. I believe the slide we showed last week, we only had 15 sites reporting. We were pulling that data in conjunction with the Nashville area office. However, it does look like the tribes have taken that task over for themselves, and they are getting better numbers, more accurate numbers than we were getting, because not all of the tribes were utilizing RPMS for this, and that's the data source we had access to pull that data. So tribes that are not utilizing RPMS or not tracking in RPMS, they're able to report additional numbers to the area office. So as of yesterday afternoon, there have been 1,289 tests performed, and that's in comparison to last week's tests. And that number is parentheses. So as of last week, within RPMS, there were 569 tests performed. We now have 69 positives, and that's cumulative positives. It's not just this week. So since this started, there have been 69 positive tests compared with 26 from last week. And there were 1,101 negatives compared with 401 negatives last week. So we are seeing an increase in testing, and we're very pleased about that. I think that that's going to really help us get a handle on what's going on within the tribal communities. So I know at the very beginning of this, there was a whole lot of talk in the media about flattening the curve and what that means. And it is my personal opinion, I do not believe that the media and maybe the CDC as well and NIH, I don't think they really were able to communicate exactly what this meant, because I heard a whole lot in my personal life. Okay, let's just all do this for 2 weeks. We'll shelter in place and it will be over with, and we'll flatten the curve, and then we can all get back to normal life. And I don't really think that they did a good job of explaining what that meant. So if you look at the bottom axis, the x-axis, where it says days since the first case, you can see the graphic of the curve that has the sharp peak, the purple curve, and then you see the gentler curve with the hash marks. That x-axis, the days since the first curve, when you flatten the curve, you lengthen the time that the the pandemic is occurring. The whole purpose of flattening the curve was not to reduce the risk of an individual becoming sick. It was to reduce the burden on the healthcare system. So it was to reduce the number of people getting sick in a very short amount of time. Unless there is a vaccine developed, we will probably not stop this in its tracks, and it will probably infect a good majority of most of us. So I think that keeping that in mind, what we are hoping for is not to completely crash the healthcare system. So you can see the gentler curve with the hash marks, that's a longer period of time. So this notion of, okay, let's just all hide out for a couple of weeks in our house and then this will be over with. I think that was the incorrect message. And I don't think that people really understood that. And I saw that in my professional life. I saw that in my personal life. I saw that on social media. I think that was a common belief. Now, if you notice, they have 1, 2, and 3 labeled on this graph. And number 1, we're trying really hard to delay the peak and to make that peak a little bit wider and gentler of a curve. And so we want to not stress the healthcare system, as I said before. And we want to hopefully diminish some of the cases that are out there and the health impacts, but also severe complications and even death. Because if we stress the healthcare system for those that are the sickest, then we have fewer resources to properly care for those people. And in addition to that, just because COVID-19 is out there, the regular business of people getting seriously ill from other things or having accidents and needing ventilator support, those things don't stop happening either. And so, it's not just COVID-19, it's being able to care for the sickest of the sick in all cases that we're trying to be able to handle. So I just wanted to give a refresher about what exactly that means, because I think that as time has gone on and we're talking about reopening, we still need to keep flattening the curve in mind as we think about that. And one of the things I've heard about reopening is about testing. And I do believe tests have their place. I know last week we talked about what you can do in the absence of a test and utilizing a case definition. I still believe that is a good tool to use. These are not either or prospects. You can use tests, but you can also use basic public health strategies like utilizing a case definition to count the number of cases. You absolutely do not have to have a laboratory confirmed COVID-19 to count a case. You can have a probable case just based on symptoms and case definition. That is a standard epidemiological tool that is utilized during outbreaks all the time. So I just wanted to pass that information on should you still have a lack of testing or a concern about some of the tests that are out there. So I wanted to talk just very briefly and at a very high level about the positives and negatives of laboratory testing. So I am not a laboratory expert by any stretch of the imagination, but I do know data and I do know numbers, and I do know there is no perfect lab test. It just across the board, it does not exist. All lab tests will have some amount of false positive and false negative results. That's just, nothing in life is perfect, and lab tests are no exception to that. So if you think about what happens on an individual level, just pretend for a second that you're a patient and you go in for a lab test and your lab test is wrong, and there's something wrong and what I'm experiencing is not lining up with what the lab test says. So that can, and this has happened to everybody, or you know somebody that this has happened to probably sometime in your life. So when this happens, that results in, on an individual level, a misdiagnosis of an individual. And that's why providers are trained to look beyond the lab test. They are trained to look at lots of different symptoms and signs that the patient may be experiencing, and not just take the lab test as it's either a yes or no, and that's the deciding factor. Sometimes it can result in additional follow-up, and sometimes we like for lab tests to have a slightly high false positive rate. So if you take cancer screening, for example, you think of a mammogram. A mammogram will pick up lots of different things and not just a malignant tumors. So sometimes you like for tests to have a slight false positive rate like mammograms do. So you have a mammogram, you find a lump, and then you get additional testing, and it either rules in or rules out a malignancy. So keeping those things in mind, just realizing that no test is perfect, and there are some reasons for that, and there are some reasons for why that happens, and providers do their best to try to overcome that. So, but when that happens to an individual, it's stressful, it's upsetting. You think, am I imagining things? Is this not right? What's going on here? And that is a really stressful situation that we've probably all been in at one time or another. But think on a broader level for a second, past the individual. What happens when that occurs to many people during a pandemic? What is the effect of that on public health? And so thinking through that, we're going to go through kind of envisioning this on what the effects could be in a pandemic situation when we apply that to lots of people. So go ahead, Brian. So again, no laboratory test is perfect. So let's talk briefly about the positives and negatives of COVID-19 testing. What are the results of a positive test mean, and what does a negative test mean? And there's something, as I said, there's false positive and false negative rates. You will also hear the terms sensitivity and specificity, and I'm not going to go into much detail about that today, but basically what they mean is a positive really positive, and is a negative really negative? And that's a statistical numbers analysis that's done on laboratory tests. But here's what we know about COVID-19 testing. And this is both the PCR test, which was the original test that the state public health labs were conducting, and also the Abbott ID test that many of the tribes have received. The Abbott test is really good at accurately identifying a true positive. So a patient comes in, they have the Abbott ID test or the PCR test, and that positive says that they have COVID. That test says that they have COVID-19. That means, by and large, they have COVID-19. Those tests are really, really good at that. So the public health measures and the clinical measures that we put in place, we isolate the patient regardless of their symptoms. We quarantine the household. The tribe or the local health department may trace contacts and evaluate them for testing, or will apply a case definition to them. And then there's an amount of follow-up with the patient in the household. So that is for a positive test, regardless of if that person has symptoms or not. Now then, a person comes in, they get tested, maybe they have symptoms, maybe they don't, and they're negative. So here's what we do know. A negative may not truly be a negative for now. I know Dr. Mira talked about the false negative rate on previous echo sessions, and the rates that I've heard varies between the Abbott ID and the PCR for different reasons. And there are some steps I know with the Abbott ID that can reduce the false negative rate. But as of right now, there is a fairly high number of of false negative tests. So thinking through that, what does that mean for public health? And so if we can go to the next slide, we'll talk about that. So to recap, with the current test, if you test positive, you're positive. I think most people are comfortable with saying that a positive is a positive, but a negative may not really be a negative. So after getting these tests in place, I've heard a lot of chatter this week and a little bit last week about, okay, we've got these tests now, let's screen everybody. Let's just test everybody. It can't really hurt, can it? So I wanted to take you through a couple of different scenarios, thinking through that it can hurt. And let's try to reduce the harm that can come from that. And I'm not suggesting not to mass screen, but to be very, very careful about it. So first of all, the Abbott ID Now test is not designed for mass screening. It's only designed for people suspected of COVID-19 by their healthcare provider. We do not know if we mass screen, if the false negative and if the false positive rate will change. It might not, but we do not know that yet. The PCR test is probably a little bit better suited to mass screening, except for the fact that it takes a while. And there's some transport questions about the samples. And if we start utilizing a lot of PCR tests, there's some concern about lab capacity. So there's some limitations to testing everyone right now. Go ahead and go to the next slide. So let's work up an imaginary scenario in which we do mass test everybody, either using Abbott or PCR, doesn't matter. Let's just think about a scenario in which we do that. So we come in and we test everybody. And we have some positives and we have some negative results. That's going to be a given. So true positives. So we know that with the current test, a true positive is a positive. We're not going to have many false positives. So what do? We have true positives. We do what we did in the previous scenario. We isolate and quarantine. We do contact tracing. But one of the downsides, or not downsides, but one of the potential impacts is mass testing and getting all of those true positives will have resource stress and community stress. And I'm not suggesting that you not do it. I'm just saying to take those things into consideration, the resource stress that will occur and the community stress, and take steps to reduce that if possible. If you have false positive results, which is also unlikely right now, it's probably unlikely that you're going to get a lot of false positives. So if you have false positives, you're going to do the same thing, right? So you screen somebody, the test shows up that they have COVID-19, but maybe later on you, determine that they did not have a positive result. So you do the same thing. You isolate and quarantine, you give guidance, contact tracing, community resources can be stressed. One of the downsides of having a false positive is that people could eventually become annoyed and mistrustful because of a misdiagnosis. But by and large, your actions will be the same. You'll isolate, you'll quarantine, give guidance, and follow up. I think Angela had her hand raised.
I'm sorry if this is a dumb question, but I know there are some viruses out there that once you test positive, you always test positive. Do we know enough about this virus that if I test positive today, 2 weeks from now, will I test positive?
No, probably not with this PCR or Abbott ID. Dr. Mira talked about that last week. It does look like there are some additional positive tests that may continue on for a period of time. but that appears to be, if I recall correctly, fragments of the RNA. I am not getting into the antibody testing that
Sure.
is going to be talked about. Dr. Brown's going to talk about that next week.
Okay.
Because that's not really, right now, that is not a consideration, although I do expect in the coming weeks, we're going to hear more about that.
Thank
As
you.
those get FDA approved. But thank you. I don't think that that's a dumb question. I think that that's a really good question. But as of right now, it does not appear that utilizing the Abbott ID or the PCR test that you will be positive forever. Okay, go ahead, Brian. Okay, so let's talk about mass screening. Now, if you have, that was the scenario with positive results. What could potentially happen with mass screening and positive results? Let's talk about what could happen with mass screening and negative results. True negative results, which is likely in mass screening, that many of the negatives will be negative, provides relief to the patient. They're relieved that they do not have COVID-19. Will that relief change that person's behavior? Because we know if they have a negative, that means that they are not sick with COVID-19 right now. That's what we know. Will they move around more? Will they stop practicing social distancing? Will they become a little less careful based on those negative results? And if you apply that to a lot of people, will it make the community feel like it is safe? And to Angela's point before, you know, if they were sick before and now they're negative, we don't know how long immunity lasts for. Will that also play into it and make them feel like, well, I had it and now I'm good, so I'm good to move around? And we don't know the answer to that question just yet. So that's my concern with the true negative results. With the false negative results, which is currently likely, at least to some degree, in COVID-19 mass screening, the same thing happens, going to provide the relief to the patient. Now remember, this is a false negative result. So they do actually, this imaginary person or people actually have COVID-19, but they have a false negative. Does it provide a relief to the patient? Do they change their behavior? And will it make it seem like the community is now safe if you have a fair number of false negative results? So that's my concern about the mass screening, is that not the positives that it identifies, but the number of negatives and the impact of the negative results on the community. So with that said, Brian, go ahead and go to the next slide. Our current recommendations is reconsider mass testing for right now at least. You can still use a combination of testing suspected cases, and the definition of suspected cases has loosened up. It's no longer just a fever. Clinicians can use their clinical judgment. They can go based on other symptoms. They may even, if they have close household contacts with no symptoms, testing those people as well. But you can still use a combination of testing and the case definition, which we outlined last week, and contact tracing to count the cases. As I said before, you do not need an absolute positive laboratory confirmed test to count on a case. There are ways to do it that are reasonable, standard epidemiological ways to count cases, and the USET Epicenter can help you think through that. That said, I totally get the appeal of mass testing. I really do. And this was something the Epi team actually discussed internally about 4 weeks ago about what guidance we would give based on the information that was currently available. And when the Abbott ID came out, we were all excited thinking that this would be a great tool for that. And then when we researched more, we realized that it wasn't. So I do understand the appeal of mass testing. But if you do decide to conduct mass testing at your sites. Do not base any reopening decisions based on your negative test results. Instead, base your decision, you want to see a decline of positives. So you want to see the number of positive cases going down. That's going to be your indicator for a staged and careful reopening. Do not rely solely on negative test results to clear workers for duty. There are other actions you can take, such as measuring temperature, monitoring, in addition to requiring masks and other, just depending on what that person's job is, social distancing and other public health measures you can take. But don't rely solely on the negative test results to think that people are clear and ready to work. And to my point earlier about not community and people not understanding flattening the curve, I do really think that a comprehensive and robust community education campaign regarding the limitations of testing and the continued need for social distancing and other public health measures is essential. There is so much misinformation out there right now that I think a very clear message about a negative may not be a negative. And we can't just go back to normal overnight based on negative test results, I think is essential for the community to understand. I shared something that happened on Facebook yesterday. Somebody posted that a local grocery store was completely out of tonic water, and somebody responded and said, oh, that's because the quinine in tonic water, it helps with the coronavirus. So people are taking small nuggets of truth. For those of you who don't know, quinine, which is in tonic water, was originally a malaria preventative and a malaria drug, and so is the hydroxychloroquine, which President Trump recommended a while back. So there's some logical thinking behind that, and it's not completely an off-the-wall idea, but it's also, when you look at it scientifically, the tonic water is not going to help your coronavirus, but it's just a little nugget of truth that gets out there without a full understanding of the whole picture that I think breeds this misinformation and confusion that I have seen out there in the community. And so with the testing, I'm seeing it, on Facebook and in my personal life. Well, I need to get tested. I need to get tested. I need to get tested. If I get a negative, I'll be so relieved. And I really think that message needs to be reinforced, that may not be the case. So go ahead, Brian, to the next one. So just keeping those things in mind, if you do decide to do mass testing, I think is going to be very important. You can reach out to the USET Epicenter, any of the USET staff to help you with this and to think through it. I know that we have fielded several questions from different sources. One of our tribes, the gaming operations, reached out to us to ask for some guidance on their reopening. And I was very pleased with how they were thinking about it and how careful they were thinking about it and some of the things they can institute to make sure that people, well, let me back up. I say make sure people are safe. The goal in reopening and the goal is to reduce risk. We will not eliminate it. So we're not making sure people are safe. We are doing our best to institute measures to keep them as safe as they can be. Risk is a continuum, and I think that we need to keep that in mind at all times. So again, I just wanted to mention a couple of innovative solutions, and I wanted to hear from you all to see if you could please share anything that you're doing at your site. So one of the things that you can do is to utilize the tool that we created, the surveillance tool, to track your cases, both the lab confirmed, because a positive is a positive, at least for right now, and those that meet the case definition. we can provide guidance regarding contact tracing if you need that. We'll be happy to talk you through it and to help you come up with innovative solutions. I know one tribe, they were planning on using their furloughed casino workers to do the contact tracing and follow-up. This does not take trained medical personnel to do it. All it takes is a protocol in a system to do that work, to refer that to a physician should there be anything concerning. But there is no reason that a medical professional has to do that work. So I thought that was a fantastic idea for the tribe. You know, they could utilize the furloughed casino workers. So with that said, I would like to see, what are you utilizing, either contact tracing or any other public health measures that you have either found to be working or things that you're thinking about? I would love to hear from you. And so with that said, I will open it up for discussion, both the questions for the Epicenter or anything that Dr. Mira said. Does anybody have any questions for me that I can answer, either regards to reopening or the generalities of testing? If you want more detail and nuance on the specific test, Dr. Mira or Dr. Brown, who's also on the call, could probably speak to that as well.
And everyone, you're on mute, so you could unmute yourselves if you're trying.
Kit, hi, it's Joe Solomon from Seneca Nation. I had a quick question for you.
Yes.
Have there been any changes or recommendations as far as disinfecting agents that we're using in the dental setting? I know that the EPA registered quaternary amines are virucidal. Has there been any updates to that or any changes that we should be aware of in the dental setting? And I'll go back to mute.
Okay, I am going to turn that over to either Dr. Mira or Tori Reeves, who is another epidemiologist at USET, and she is our resident expert on infectious disease epi, and she's actually writing a guidance document right now regarding disinfection. So,
thank you.
Tori, are you on?
I'm not sure she's on.
She may not be on. Dr. Mira, do you know the answer to that, or Dr. Brown?
No, I don't.
I don't know the specifics of that either. So sorry.
Dr. Solomon, if you would email or just type that question into the chat, we will find out the answer and email it back to you.
I will, sure. I mean, we're just following the standard guidance right now that's already been out there. I just want to know if there were any updates. So, but yeah, I'll type that up for you, Kit. Thank you.
Okay. And from my rudimentary understanding of the virology of this being an envelope virus, that's fairly easy to bust that envelope. So I wouldn't think that there's a lot of specialized instruction, but again, I will confirm that and get back to you.
Thanks so much.
So I just would like to make a quick comment, and thank you for your presentation. It was really good. You know, what we decided to do, and you can do this if you have the resources and the community is willing to accept it. When we had negative results, we would still, and the patients were symptomatic, of course, they had respiratory symptoms. We would still advise them to complete the isolation as if they had COVID, if it was possible, within, you know, their possibilities of work, etc. It wasn't, most of the patients complied with it. I think it was because we're still under this isolation policy, so many people were not having to go to work no matter what. I'm not sure if it's going to work that way as simple when things start to open up again, because patients will need to stay out of, you know, need to go back to work. But I think that probably had a good impact, because and maybe not on COVID a lot, but on many other respiratory infections, because these patients clearly had a viral respiratory infection. And we were trying to tell you, we were using the CDC no testing guidelines. You can go back to work 3 days after your symptoms have resolved. Get off isolation 3 days after your symptoms have resolved, and at least seven days since your symptoms started. I just wanted to mention that we are still doing that, and we're not enforcing it. It's just a recommendation we give to our patients. And the other thing is, you well said, there's a lot of false negatives out there. We don't really know which test has which. I just want to make a clarification. The Abbott test is a PCR test. It's just not a thermocycler like your normal PCRs, but it is a molecular test. And we still have not heard the last word about the sensitivity of it. There was that report that I think you mentioned that there was 15% false negative compared to another test. But I have not read the published manuscript of that report, and I would really like to do it because there's a lot of nuances. Ideally, when you have to have a gold standard that you're comparing a test to, and apparently from this report, the gold standard was another test. But I'm not sure if they did simultaneous testing with the same swabs, or they used residual liquid from whatever was left on the tube from those patients, and that can alter your results. Coincidentally, and I don't know if this has an impact or not, but Abbott, right before this report came out, Abbott suggested not using transport media or saline, or putting the swab in saline to send out to the labs. They just said send the swab directly, because apparently this test is using the swab directly and not putting in any form of media. So that could have also impacted some sensitivities. So we're still using it. We're using other tests beyond the Abbott. We're usually using the Abbott test for our in-house, our patients who are admitted. We use two tests, the Abbott and a send-out. And we are using one test for our healthcare workers, because it's the beauty of the Abbott and the Cepheid, which we have the machine, but we don't have any kits yet, is that they're rapid. So you can get a result, in 20 minutes and 45 minutes on the Cepheid machine. And that really makes it different on your management and your interventions. But like you said, the word's still not out there. We've always have dealt with false negatives and many other tests. And as long as we have a protocol on what we're going to do and decrease the confusion and the anxiety of the healthcare providers and the population, I think that's the main point. And what you said, communicating this to have clear messages to the community, what these tests means and what they don't mean.
So we had a question come up in the chat. Do you think a test will be devised that will eliminate false positives and false negatives? I'm going to turn that over to one of y'all. As I said, I'm an epi, I am not a laboratory expert. But we do know, as I said, there's nothing perfect. I think ideally, what Dr. Mira said, and Dr. Brown actually mentioned to me earlier today, the ideal would be to use two tests, one that, if one has a strength at identifying positives and one has a strength at truly identifying negatives, that you use those in conjunction with each other. But I'll let Dr. Mira or Dr. Brown answer in more detail on that.
Yeah, from my point of view, I don't think so, because we don't have, I can't think of any test that we have that's 100% sensitive and 100% specific. But what you really want is a test that reaches a very high sensitivity and a very high specificity. And from one recommendation I've read, and I can't remember what journal recently regarding COVID, is that the ideal test should have 99% sensitivity and a 99% specificity. And that would be what we would shoot for. But having said that, 80% sensitivity is better than not testing, because you can at least get some information. And I think this will improve with time, like we've seen with other tests. Just remember that these tests have gone through a fast track in the FDA, And approved by the FDA just means that, okay, you're allowed to produce it and sell it. It's not that these tests have been validated with the rigorosity that other tests have been validated in the past by the FDA. So, time will tell.
Yeah, thank you. And really the bottom line is use these tests for the information that it provides, but realize it doesn't provide all of the information that you're going to need.
And one last thing, the sensitivity and specificity also depends on the probability of the disease being present in the population that you're testing. So all these numbers improve when you're testing people with respiratory symptoms. But if you go out and test asymptomatic people, and depend where you're doing it. If you're testing in Rome, your sensitivity and specificity are much better than if you're testing in Alaska, where they have very few cases. So that's another factor that influences the sensitivity and specificity, or probably the positive predictive value and the negative predictive value of the test at the end.
Yeah, thank you for that. And that was something I was trying to allude to on that. The Abbott test has not been approved for testing everybody, and there's a reason for that. And that's what you said.
Okay, are there any other questions for Dr. Mira or Christy?
Dr. Brown, did you have anything you wanted to chime in on?
No, I don't at this
Okay.
time.
Okay.
Okay. And Dr. Brown is really going to go into a lot more detail, kind of like Dr. Mira did today, next week. I realize that we have a variety of people on this call, from providers to people who are non-clinical folk, but actually they may be administrators or whatever, but just really taking the broad view about this testing and what it's going to mean for public health.
Emily, do you want to tell them about the evaluation? You're on mute.
Yeah, I see that people are hopping off already. I have pasted a link into the chat. If you could please give us some feedback. It's just a quick 2-question survey on SurveyMonkey, and just let us know what you thought of today's session and what you'd like to see in upcoming echoes. And we will be holding these weekly on Fridays.
I feel bad for throwing one additional question out there, and I hope
No worries.
nobody minds. Is that okay?
That's fine.
Go for it.
It's Joe Solomon from Seneca again. Just a quick question for whether or not there's any guidance or maybe forthcoming guidance on employees who may have been furloughed returning to work, about a test that health centers could offer for their employees who are returning back to work. And I know you had mentioned that the Abbott test might not be the best for mass screening, but what would be a good recommendation for testing employees before they came back into a clinical setting prior to treating patients again?
So that's a great question, but I need some clarification. Are you talking about employees they're asymptomatic and were not positive, correct?
Correct. Employees who are furloughed and currently quarantining at home, asymptomatic, but that were taken out of the workforce to encourage additional social distancing at our clinic.
Right. Okay. So, actually we're working right now on how to implement that, and also on going a little bit further on travel, because, the summer's coming soon. People are going to go on vacation. That includes employees. What do we do when they come back from travel, depending on, where they travel? So for your specific question, if the employee has been in home, we would just do a questionnaire of, have you been exposed to anybody with COVID-19 or possible COVID-19? And if the answers are no to everything, and they're being asymptomatic and sheltering in place, I don't think that there's really anything that you should add to that. Now, you could say, I want to do testing, and that's fine. It'd be interesting to collect that data and that information. but it is a little bit cumbersome. You have to, it is costly. And I'm in favor of it if you have the resources to do it, but I don't think you need to do it right now. Now, if it is a little bit different, if an employee tells you he's been symptomatic, he had a respiratory infection, then yeah, that employee will need to be tested. Or if they have traveled, they've been in some place in which there's a more active transmission than in the area that you live in, maybe testing would be a consideration. And let's say you have a problem with testing because of the resources. Then the other option you could do is have them come in and the employer monitor the temperature before they come to work, have them self-monitor twice a day, and have them use a mask and keep a 6 foot isolation, 6 foot distance with the other employees at their work for a 14-day period. Those are other, I think there's several options. You have to look into what can you do where you are, what do you have available, and adapt that to the situation of the employee.
Well, thank you very much. And I'll honestly say, if there's guidance like that that's forthcoming for, various unit directors or clinic directors and stuff like that, I think that's going to be very helpful. So your explanation was very appreciated, but I think everyone would really anticipate, and that sort of guidance would be very welcome. So thank you very much.
Sure. Well, when we put it together in writing, which will be soon in the next 2 days, actually, I'll be happy to share what we do. Does not mean it's a guidance for everybody, but at least it's telling you what we do in our facilities. And then if it's helpful for you, you can adopt it or tweak it to your needs.
And that's something USET has been working very closely with the area office on some of this guidance for providers that we're giving and guidance, just because we want to have the same message as the area office when they're giving advice to the service units versus the direct service tribes. So we've been collaborating with them, and we can see that if this would be something that would be forthcoming.
Thank you again.
Okay.
Is that it with the questions?
Hi, can you hear me? This is Desiree calling from the Wampanoag tribe.
Yes, ma'am.
I don't know if it's a question statement, but since January to present, I'm a substance abuse counselor, and I've had between 7 and 10 patients that have went into the hospital, and couple have went in twice. They have been COVID tested. It comes back negative, and they're positive for pneumonia. And I didn't know, I've never had that many patients during such a short period come back with the same symptom. One patient actually passed away in March due to pneumonia, and then they're going back home to their families. So my concern has been, I think that was discussed earlier, is when they test negative, there's like a relaxed atmosphere in the home of, well, they had the test and everybody's, they just have a whole different attitude about it, and they tend to go out and do other things. Didn't know if anyone else had seen anything like that.
So are you asking if we've seen situations of pneumonia with COVID at negative tests? Is that the question?
Yes.
Yeah, okay, yeah. So, it's a very interesting question. Remember that before the COVID pandemic, 40% of the pneumonias, doing the best testing you can, you still do not have a diagnosis. You only get a diagnosis in about 50 to 60% if you are very thorough in the testing. And when I mean very thorough, I mean blood culture, sputum culture when sputum is available, multiplex PCR to detect a bunch of other viruses, influenza, other coronaviruses, etc. Pneumococcal antigen in the urine and Legionella antigen in the urine. Well, doing all of that, because we did a systematic study, we haven't published it yet, it was 2 years ago, 1 year doing that, all of that in pneumonias who were being hospitalized. And we only came up with the diagnosis in 58% of the patients. 40% still will not have a diagnosis. Now, having said that, in the COVID epidemic, in the context of the pandemic that we're living, if we have a patient with pneumonia that we don't have a diagnosis, and when they're ready to be discharged, we would still keep them in isolation until they meet the no test criteria by CDC, just to be on the safe side. Meaning, you have to be isolated until 3 days after your symptoms have improved, and at least 7 days since your symptoms initiated. If you want to be safe, that's what we recommend. But it could have been a COVID false negative, or it could be that they just had a coronavirus of some other sort, or influenza, they were not tested for it, or RSV. There's a bunch of other viruses that can cause pneumonia, or bacteria. That's all I can say regarding to your question. Thank you.
Okay, are there any last questions? If not, don't forget to submit your surveys, share your feedback on the survey, and we will have another call next Friday at 11 Central, 12 Eastern. Thank you, everyone.
Thank you.